final section of this course is on heart blocks. An AV block is characterized by impulses that are disrupted during conduction from the atria to the AV node and then to the ventricles. An AV block can occur at either the level of the AV node or just below it in the bundle of his or its branches. Some patients experience total AV blocks, while others have partial or delayed impulse transmission. Some AV blocks are temporary, while others are permanent. All AV blocks, however, are classified into one of 3 degrees based on the severity and the location of the block. From the mildest or first-degree AV block to the most severe third-degree block, accurately diagnosing a heart block is critical. Your approach must be methodical and reliable, because the choices you make based on your diagnosis could save a patient's life.
The first-degree heart block is the least severe. The electrical impulse begins in the SA node, but is delayed in the AV node. The impulse then conducts normally through the ventricles, but while the AV node is supposed to delay the impulse, in this scenario, it holds it longer than it should. Therefore, the impulse is not really blocked, but rather delayed. When naming a first-degree heart block, you must first identify the underlying rhythm. The PR interval is the key to identifying this rhythm because it represents atrial depolarization through the AV node. This delay prolongs the PR interval to greater than 0.20 seconds, which is really the only thing that differentiates it from a normal sinus rhythm. The ECG characteristics for a first-degree heart block are as follows. Rate. Atrial and ventricular rates are the same, usually normal, but it depends on the underlying rhythm. Rhythm. Atrial and ventricular are regular. P waves. Normal in size and shape, with one coming before each QRS. PR interval. Prolonged, greater than 0.20 seconds, but constant. QRS. Usually normal, 0.04 to 0.10, unless there is an interventricular conduction delay. A first-degree block may be normal in some individuals, especially athletes. It may also present with ischemia, myocardial infarction, rheumatic heart disease, or with electrolyte disturbances. It may also be drug-induced. This is usually a benign rhythm that generally does not require treatment. Assess the patient, though patients are usually asymptomatic. If it's the first time onset, monitor the patient because the first-degree block is a rhythm that can lead to worsening or even a more severe heart block. A patient with myocardial infarction that presents with this rhythm should also be monitored carefully. A bundle branch block, or BBB, is the abnormal conduction of an electrical impulse through either the right or left bundle. You must first identify the underlying rhythm. The electrical impulse begins normally in the SA node and travels to the AV node, but it also arrives at the bundle branches. It is able to travel down only one of the 2 bundles. This traveled bundle is depolarized, and then the impulse spreads to the other ventricle and depolarizes it. This causes ventricular depolarization to take longer than normal. Therefore, the QRS is wider than it should be, and it is greater than 0.10 seconds. In bundle branch block, each QRS is equal to or greater than 0.10 seconds, while everything else is normal. A 12-lead ECG is used to determine whether the rhythm is a right bundle branch block or a left bundle branch block. Here's how. Move from the J point back to the QRS complex and examine the last 0.04 seconds. If the terminal portion is positive, with an upward deflection, it is probably a right bundle branch block. But if the terminal portion is negative, with a downward deflection, it is probably a left bundle branch block. These 2 rhythms, the first-degree block and the bundle branch block, are the least threatening of the heart blocks and are the easiest to identify. A first-degree block is characterized by a prolonged PR interval, and the bundle branch block will have the wide QRSs greater than 0.10 seconds. A right bundle branch block most commonly occurs with some type of heart disease, such as an anterior wall myocardial infarction, coronary artery disease, or pulmonary embolism. It is also more likely than the left bundle branch block to progress to a complete heart block. The left bundle branch block can either be acute or chronic. The most common causes are coronary artery disease, hypertensive heart disease, and/or dilated cardiomyopathy. With either the left or right bundle branch block, ECG changes may be indicative of an acute myocardial infarction, which will require prompt, appropriate intervention. The treatment process is to assess the patient, determine the underlying cause, and then treat accordingly. Even though they may often present little immediate danger, bundle branch blocks should be monitored for possible progression to a more serious condition. With symptomatic bradycardia, commonly seen with bundle branch block, treatment may include atropine or a pacemaker.
There are two types of second-degree heart blocks, type 1 and type 2, which are categorized by whether the partial blockage occurs above or below the bundle of His. Type 1 is sometimes referred to as Wenkenbach or Mobitz 1, and it occurs at the level of the AV node. As the sinus node initiates impulses at a rate of 60 to 100 beats per minute, each impulse is delayed at the AV node just a little longer than the preceding one, until one is eventually blocked completely. The PR interval will therefore progressively lengthen. The impulses that are conducted travel normally through the ventricles, so the QRS is normal, although some may be dropped altogether. The ECG criteria for a second-degree heart block type 1 is as follows. Rate. Atrial rate will exceed the ventricular rate. Rhythm. Regular atrial, irregular ventricular rhythm. P waves. Normal in size and shape, but some Ps are not followed by a QRS. PRI. Lengthens with each cycle until a P wave appears without a QRS complex. QRS. Constant, 0.04 to 0.10 seconds, with some periodically dropped. Type 1 may also present as a 2-to-1 AV conduction pattern, which occurs when 2 P waves occur for every QRS complex. The ECG criteria for a second-degree heart block type 1 is as follows. Rate. Atrial rate will exceed ventricular rate. Rhythm. Varied atrial. P waves. Consistent in upright form, but PR intervals will gradually lengthen until one QRS complex is completely dropped. PRI. Constant. PRI shorter, longer, longer, dropped. QRS 0.04 to 0.10 seconds. A second-degree heart block type 1 may occur with the use of some drugs such as digitalis, calcium channel blockers, or beta blockers. It is also associated with heart disease and myocardial infarction. The treatment process begins by assessing the patient, but the patient may not be symptomatic since the ventricular rate remains close to normal and cardiac output is not affected. If the patient is symptomatic, however, determine and treat the cause. You may have to withhold drugs if toxicity is the issue. And if the heart rate is slow and the symptoms are serious, use atropine. This condition may sometimes require a pacemaker. No matter the severity of the symptoms, continue to monitor the patient for possible changes or worsening of their condition. A second-degree block type 2, which is also known as Mobitz 2, usually occurs below the AV node. The sinus node discharges at a normal rate of between 60 and 100 beats per minute, but the impulse is usually generated from bundle branches. causing dropped beats. Because the conduction delay is below the AV node, type 2 is more serious than type 1 and is more likely to progress to a complete heart block. Treat the patient and consider pacing if symptomatic. This problem in type 2 occurs farther down the conduction pathway in the bundle branch. Because the impulse is lost, the QRSs will be missing and the ventricles take longer to depolarize, so the QRSs that do show up are wider. The P waves in the PR interval, however, are normal. Let's look at the ECG criteria for a second-degree heart block type 2. Rate. Atrial rate will exceed the ventricular rate. Rhythm. Regular atrial and irregular ventricular rhythm. P waves. P waves are normal, but all P waves are not followed by a QRS complex. PRI. Constant. QRS. Wide, usually 0.10 seconds or greater, although some are dropped. Type 2 blocks may also present as a 2-to-1 AV conduction pattern, where 2 P waves occur for every QRS complex. The ECG criteria for a second-degree heart block type 2 with a 2-to-1 conduction pattern is as follows. Rate. Atrial rate will exceed the ventricular rate. Rhythm. Regular atrial and regular ventricular rhythm. P waves. There will be 2 P waves for each QRS complex. PRI. Constant. QRS. Greater than 0.10 seconds. To differentiate between the second-degree AV block type 1 and type 2, review the PRI to see if it's constant or lengthening. With type 1, the block is in the AV node, which produces a lengthening PRI and normal QRS measurement. With type 2, however, the block is below the AV node, so the PR is constant and the QRS is wider. Heart diseases associated with second-degree AV block type 2 include myocardial infarction and left coronary artery disease, in which the LCA supplies blood to the bundle branches. For treatment, assess the patient because they will likely be symptomatic and may well progress to a complete AV block rather quickly. If the patient is indeed symptomatic, apply a temporary pacemaker device. If the transcutaneous pacemaker is ineffective, administer a dopamine or epinephrine infusion to support blood pressure until a transvenous pacemaker can be inserted.
With a third-degree heart block, the width of the QRS complex is related to which secondary pacemaker the heart is using and the current state of the interventricular conduction system. If the QRS is between 0.04 and 0.10 seconds, the block is considered to be at the AV node level. The heart is using the junctional pacemaker. If the QRS is greater than 0.10 seconds, the block is considered to be at the bundle branch level. The heart is using the ventricular pacemaker. The ECG criteria for a third-degree heart block is as follows. Rate. The atrial rate is greater than the ventricular rate. The ventricular rate is 40 to 60 beats per minute if blocked at the AV node, and 20 to 40 beats per minute if blocked at the bundle branches. Rhythm. Regular atrial rhythm, although some P waves may be hidden. Ventricular rhythm is also regular. P waves. Normal in size and shape. There is no relationship between the P's and the QRS's. P waves can also be hidden within QRS and T waves. PR interval. There is no measurable PR interval because the atria and ventricle are working independently of each other, each firing their own pacemaker rate and rhythm. QRS. Normal. 0.04 to 0.10 seconds. If blocked at the AV node, wide, greater than 0.10 seconds if blocked at the bundle branches. A complete heart block at either the AV or BB level is associated with inferior or anterior myocardial infarction. To begin treatment, assess the patient and apply a transcutaneous pacemaker. If the transcutaneous pacemaker is ineffective, administer a dopamine or epinephrine infusion to support blood pressure until a transvenous pacemaker can be inserted.